third speaker is Dr. Eran Horowitz from Israel. He will be talking on Pergoveris, human recombinant FSH 150 IU and recombinant LH 75 IU, a new gonadotropin preparation in art. Professor Eran Horowitz from Israel. Dr. Eran.
Okay. Good morning to everyone. Okay, as we all know, the goal of our treatment is to have finally one healthy baby. Pergoveris is a new preparation that is made of 150 recombinant FSH and with 75 recombinant LH mixed together. Just briefly, I'd like to talk about the two-cell theory. We all know that in order to have follicogenesis, we need to have the TECA cells. The LH receptor work on it, and it transfers the cholesterol to androgen, which then go to the granulosa cell, and by the FSH, we have the aromatization, and then we have the estradiol. The role of FSH in the menstrual cycle is to have the dominant follicle. The FSH drives the follicular development. It induces the aromatase activities on the granulosa cell, and of course induce estradiol secretion. It also induces LH receptors on granulosa cell, which is important for the steroidogenesis. And of course we have the negative feedback of the estrogen on the hypophyse, which causes the decrease of the FSH, and then we have only usually one dominant follicle. The role of LH in the menstrual cycle is also important. During the follicular phase, it promotes the androgen secretion in the TECA cell. Its synergistic action with the FSH in producing the estrogen, and during this follicular phase also support the dominance once the FSH levels decrease. During the mid-cycle, we all know it's important for the resumption of the oocyte meiosis, maturation of the cumulus oocyte complex, and helps to have the follicular rupture and then the granulosa luteinization. And of course, during the luteal phase, it maintains of the corpus luteum and progesterone secretion, which is critical for the implantation of the embryo. We know that there is a LH therapeutic window. If the level of the LH is less than the threshold, the follicular growth may be impaired. There would be inadequate androgen and estrogen synthesis, and no full oocyte maturation. If we have a LH level more than necessary, and what is called LH ceiling, we may have suppression of the granulosa cell proliferation. We may have follicular atresia, sometimes premature luteinization, and the oocyte development may be compromised. So the FSH threshold concept means that the follicular recruitment and growth are dependent of FSH threshold. Below that threshold, follicular growth is arrested, and initial follicular growth is independent of LH, but there is an LH threshold for adequate steroidogenesis, and the LH excelling concept means that the growing follicle needs limited amount of LH, and above this level the progesterone is arrested. and of course high amount of recombinant LH could arrest the follicular growth. What we know about LH supplementation in ART. We all know that only 1% of the receptor activated to accept all the exchanges that we recently reviewed. So we need only 1%. Usually the majority of the patients do not need LH supplementation as the endogation level is sufficient, and therefore LH supplementation seems to be beneficial only in subgroups of the ART patient population. So if we look for using recombinant LH in non-selected ART population, we have here the meta-analysis of Kolbiankis in 2007 Human Reproduction Update. And what he showed that in unselected ART population, there was maybe a slight advantage for the recombinant FSH if we compare it to the recombinant FSH and recombinant LH. So his conclusion was that there is no benefit observed for supplementary LH in unselected women undergoing ART. However, heterogeneous studies and subgroup of patients may benefit from the addition of recombinant LH. So maybe using LH according to the endogenous level of LH, maybe that's the solution. Kolbiankis published again in 2006 in Human Reproduction Update another meta-analysis, and the question was, are endogenous LH level during ovarian stimulation for IVF using gene-reg analog associated with the probability of ongoing pregnancy rate? And according to his meta-analysis, he showed that none of the retrospective studies suggest that low endogenous LH levels, I mean, not in the stimulated cycle, are associated with a significantly decreased probability of ongoing pregnancy rate beyond 12 weeks in such patient. So it means that if you have endogenous low level of LH, those patients will not benefit from using the recombinant LH. So the next question was maybe using recombinant LH according to the ovarian response, maybe that would be beneficial. So in 2010, there was a consensus of the ASRM and the European Association ESHRE on the definition of poor responder during ovarian stimulation, because till that time there were many definitions, so we didn't have the same basic for doing research about poor ovarian reserve. And the result of this definition was that in order to define poor ovarian reserve, we have at least two of the following three features. One is advanced maternal age, more than 40 years, or any other risk factor for poor ovarian reserve. The second one is a previous poor ovarian reserve, which means less or 3 outside retrieved in conventional stimulation. And the third one is abnormal ovarian reserve test, like anti-follicle count less than 5 to 10, or anti-Mullerian hormone less than 1.1. There was a publication in 2011 in Italy. They look for almost 4,000 patients going the first cycle for IVF, and they look for the percent of patients that had less than 4 outside, which means poor ovarian reserve. And as we will think it will be that as the age goes up, we have more patients with poor van reserve. So if we have patients after age of 40, it's between 20 to 40% with poor van reserve, which is accepted. So in order to try to answer the question if the patient with poor van reserve can enjoy the aid of recombinant LH, a paper in Italy in Human Reproduction in 2005 tried to answer this question. In the study, there were 260 normal gonadotropic women. They used the long protocol, starting dose of 225 recombinant FSH, international unit. They consider a suboptimal responder if on day 8, the day of stimulation, there was less than 180 picogram milliliter estradiol level and 6 follicle between 5 to 10 millimeter. And they divided this group of patient to 3 groups. The first one received 150 international unit of FSH, of recombinant LH daily, with the same amount of recombinant FSH. Group B had increased the amount of FSH, only recombinant FSH, okay, by 150, and the subgroup was a normal responding woman. What we see here in the result, sorry, is that the E2 level was significantly higher in the group that received recombinant FSH. Again, they didn't increase the amount of